Good morning, everyone, and thank you to Greg and Jenny for the invitation today and the opportunity to speak with you all. It's really great to see so many people coming out. And so I've been asked in this part of the talk to really discuss how we treat newly diagnosed patients with myeloma. And so I'll give just a little bit of background and then talk about really where we are with induction or initial therapy for myeloma in 2018. And I'll go through a few general principles about how we think about which therapies to choose, and then specifically talk about what might be coming next. And I've tried to focus on that in a lot of the talks in terms of not just what we're doing now, but where we might be treating patients a few years from now. And then I'll briefly talk about the role of stem cell transplant and maintenance, again, for newly diagnosed patients. And so this is really our general approach, if you look sort of as a general overview for a newly diagnosed patient in 2018. I'll talk a little bit about induction therapy. And as Dr. Usmani mentioned, the goals of initial therapy are really to get rapid control of the disease, improve symptoms for patients who have severe bone pain, improve performance status, people who are maybe debilitated by that pain, improve organ function if there's kidney failure, and get that initial deep hematologic response. And as I'll talk about, and as we've alluded to, this is generally with at least 3 drug combinations given at full doses and at the most intensity in the beginning. And then for a subset of patients who are eligible for an autologous stem cell transplant, this still is one of our preferred modalities of treatment, and I'll talk about the rationale for that. And this is really to try to deepen that initial response and prolong that remission. And then now we have a lot of data suggesting that maintenance therapy, which generally still is with one drug given at lower doses, lower frequency, can again maintain that remission. And the goal during this time frame is really minimize toxicity, maximize quality of life, try to get you back to how you were before the diagnosis, and of course extend survival. And so these are the different goals for the different phases of treatment. And so when we look at the therapeutic landscape of myeloma, for close to 4 decades, all we really had were the classic cytotoxic chemotherapy drugs, melphalan, either in low doses or high doses with transplant, cyclophosphamide or doxorubicin, and corticosteroids. And this was really it for a long time. And the first real breakthrough and movement into the novel era of myeloma was when we developed proteasome inhibitors, and Bortezomib was the first in class, and now there's several others, and the IMiDs, immunomodulatory drugs. And these really started to be used in the late 90s, early 2000s, and really have changed the treatment landscape of myeloma and improved outcomes. And now we've gotten even more different classes of medications. We have the monoclonal antibodies for the first time, approved in 2015. Daratumumab, or Darzalex, targets a protein called CD38 on the surface of the myeloma cell. And Elotuzumab Emplicity, which hits a protein called SLAMF7, or CS1, also on the target of the myeloma. And we now have another class of therapy called histone deacetylase inhibitors, and the one that's been approved is called panabinostat, an oral treatment. And this is not all, this is what's available to us right now, but there are all these new approaches that you're going to be hearing about perhaps more in the afternoon, novel drugs, venetoclax, new antibodies, and of course all of the immune therapies that I'll be discussing later. And so the good news is that we can combine all of these different treatments together. And Dr. Usmani showed a very similar slide. And as you add more drugs together, you start to get higher response rates, and particularly more deeper responses, very good partial or complete responses. But it can get to be a bit of alphabet soup here, and it can be very complicated. And how do you choose which of these combinations you're going to use? And so I'll try to go through some of that data. So one way to think about how to choose is based on toxicities and side effects. And I think it's important to mention this, because while these drugs are certainly better tolerated than our old-fashioned chemotherapy drugs of 2 or 3 decades ago, they do all have their own side effects. What I always tell my patients when I go through side effects is just because it's listed doesn't mean you're going to get all of these. But it's important to sort of know what to expect. And for particular patients who have other medical issues, that may help you choose. So a patient who has significant diabetes and bad diabetic neuropathy may not tolerate Bortezomib well, which causes neuropathy. Patients who have significant prior cardiac history or congestive heart failure, you may have difficulty with a drug like carfilzomib where there's that risk. And so it's important to sort of know what the possible side effects are and help manage those, and that can help you choose therapies. But when we really think about induction therapy in 2018, I think the first general principle, and one that's really been generally universally accepted, is this concept of triplets. 3 drugs are better than 2. And you've heard a lot about the rationale for this. There's a lot of heterogeneity of the myeloma clones within the bone marrow. And I think for a while there was a debate where maybe you could just use 2 drugs like Bortezomib and dexamethasone first, and then move to Revlimid and dexamethasone next, and you could sequence these drugs out and maybe get the same outcomes and not have as much side effects. But from a number of studies, but first in the relapse refractory setting that we'll probably hear about later this afternoon, and then in this important trial, really it's been demonstrated that using these 3 drugs up front, patients have better outcomes than just starting with the 2 drugs. And so this was an important study by the Southwest Oncology Group. It's a U.S. Cooperative group, multiple centers around the country. And the study was written in 2007 and published in 2016. So it shows you how long some of these studies take to read out. But this looked at lenalidomide, Revlimid, Bortezomib, and dexamethasone given for 6 months as initial therapy versus just lenalidomide and dexamethasone alone. And this was a mix of patients, some of whom were older patients not eligible for transplant, some of whom were eligible but decided to put off transplant for later. And after the 6 months, they all went on to just maintenance with lenalidomide and dex. And what they found was just that initial 6 months of therapy had prolonged impact on outcomes. The progression-free survival was increased by a median of 13 months, and importantly, overall survival was better in the group that started out with the 3 drugs compared to the 2. And so this was really the first randomized study to show that a modern triplet was really better than a modern doublet and had a long-term impact even beyond the initial time period. The second principle that I'll say has emerged, I think, in the last couple of years is that the type of drugs you use together are important. And so there were a number of these triplets that were available to us combining different drugs. And the ones that were, I think, most commonly used in the US were a combination of a proteasome inhibitor like Bortezomib, an immunomodulatory drug like Revlimid or thalidomide and dex, or a proteasome inhibitor and cyclophosphamide, an older chemo drug. This has been called Cy-Bor-D or VCD. And there was thought that these were largely interchangeable and you could choose which one fit better based on the patient and preference of the physician. But there have been a number of studies coming out, some prospective randomized trials, some retrospective, suggesting that the proteasome inhibitor IMiD may lead to deeper and higher response rates up front than the proteasome inhibitor with cyclophosphamide. This is a French study where they were randomized to one of these 2 combinations with higher and deeper response rates if they got the proteasome inhibitor with the thalidomide in this case. This is a retrospective study from Mayo Clinic, again, looking back at patients who got either Cy-Bor-D or VRD, Velcade, Revlimid, dex, and again, higher and deeper response rates. And so I think this has led at least myself and most of us to change our practice and really try to get that proteasome inhibitor IMiD combo in most patients. Now, there are some caveats with these data. A lot of it's retrospective. There's not a lot of data on long-term outcomes, and so while the response rates are higher in the beginning, does that really translate to better survival down the road? Patients with kidney failure often need to start treatment right away, and it's difficult to get the IMiDs. There's this, approval process with insurance that can take time, and so this is still a situation where I may start with Cy-Bor-D, a Bortezomib cyclophosphamide combo. But again, I think this is another principle that we're looking at in 2018. And then I think the other principle that's emerging, I think a lot of us have used this VRD, Velcade, Revlimid dex combination, but there's another proteasome inhibitor called carfilzomib or Kyprolis that's approved for relapse refractory myeloma that's showing a lot of promise in early studies for newly diagnosed patients. And so I've listed here 4 different trials, all phase 2 studies, relatively small, looking at carfilzomib or Kyprolis with Revlimid and dexamethasone, the KRD regimen. And these were different. 2 of these just gave the KRD alone for prolonged periods of time and then went to maintenance. 2 of them incorporated an autologous stem cell transplant followed by maintenance. But the bottom line is these response rates close to 100%, and particularly deep responses, 80 to 90% rates of very good partial response, high rates of complete remission, and even MRD negative rates are higher than we've really seen with some of the other VRD or Cy-Bor-D type trials. Now again, the caveats of this, they're very sort of small studies, and early on, the impact on progression-free and overall survival looks good, but again, not a lot of follow-up. And the trade-off, perhaps, with this is that there are some particular toxicities with carfilzomib, particularly cardiovascular toxicities that are starting to emerge. And this is a study that was done by one of my colleagues at Penn, Adam Waxman. There have been several others. We're looking at patients who had carfilzomib-based combinations. There may be a higher rate of certain cardiac events, new hypertension, even congestive heart failure, atrial fibrillation. And this is a relatively low percentage of patients, severe cardiac issues anywhere from 5 to 10%, but it's something to keep in mind. And so there have been some centers that have decided they're going to give KRD to every patient because these data look so good. Others have proposed maybe let's do this for our high-risk patients and use VRD. I think the jury is still out. I happen to be a bit of a late adapter, and I'm waiting for more of the randomized data and data in more patients before recommending this for everyone. But I think this is emerging as a new option for our patients, and certainly the early data looks good. And the question is just going to be, what's the toxicity going to be? And so I think the take-home points for induction in 2018, I think VRD remains the most commonly used regimen in the USA. And even in older patients who are not eligible for transplant, you can usually get this triplet in. There's a VRD light regimen where the Velcade's given once a week and you use lower doses. I still think doublets may have a role, like lenalidomide and dex, all oral, in very frail patients, a lot of medical problems. You don't think they're going to be able to tolerate the triplet. But in most patients, we try to get the triplet. CyborD, as I said, still can be used with, I use it in patients with kidney failure initially, or if patients can't get lenalidomide or can't tolerate it. And KRD, I think, is emerging as a nice new option, and there's recommendations perhaps for high-risk patients. I'll point out there is a very important randomized trial going on in the United States, head-to-head comparison of VRD and KRD. That's still accruing, going to be 1,000 patients, and so we're encouraging any newly diagnosed patient to potentially go on this study to really get a true head-to-head comparison for this. And in most cases, we're doing 4 to 6 cycles for a transplant candidate and then going to transplant, whereas those who are not candidates, we may treat them longer with the initial therapy and then move on to maintenance. So that's what's going on right now. The question is, can we do better? We saw from Dr. Usmani that the complete remission rates and minimal residual disease negative rates are still not as high as we would like. And so what I say, the rise of the 4-drug regimens. In oncology, we always think, oh, more is better. So if we have 3 drugs, why not add a 4th? And I'll say that historical approaches to do this using old chemo drugs like Cytoxan and doxorubicin, when they were added to VRD, they seemed to cause more toxicity and didn't really help. But we have a new set of drugs in town, and these are the monoclonal antibodies. I mentioned them earlier, Daratumumab or Darzalex and Elotuzumab Implicity. These really work in a very different way than all the other drugs that are used currently. They were approved for relapsed refractory myeloma, and the question is, can you use them early in newly diagnosed patients and maybe not get that toxicity, but get good efficacy? And so the first trial that's read out using daratumumab up front for myeloma was just published in the New England Journal recently. This was for older patients. This was mostly a European study who were not getting a stem cell transplant. It used an older regimen called VMP, Bortezomib with melphalan and prednisone. Not used that much in the US, but still commonly used in Europe. And so the patients either got 9 cycles of VMP, which was the standard, or they got the experimental arm with VMP plus daratumumab, and then they went to daratumumab maintenance. So a little bit of an unfair comparison. One arm got maintenance, one didn't. But this was sort of the standard at the time was just 9 cycles and stop when this was designed. And you can see much higher response rates overall, very good partial response and complete response in the group that got the Dara. And the progression-free survival, the patients who were still alive and their disease had not progressed or gotten worse, was better if you had daratumumab than if you didn't. Now, the trade-off, there were slightly more infections in the daratumumab arm. Most of these were low grade, but there were an increased rate of pneumonia, so some increased toxicity. But overall, this was tolerated. The overall survival data was immature, really short follow-up. But I think this is likely to get this drug approved in the frontline setting for the first time in Europe and potentially in the United States as well, and showed us that we could potentially add these together and maybe get better outcomes. So we don't use VMP much in the United States. We use VRD or KRD. So what about adding these new antibodies to these regimens? And so far the data that's been presented has been very small studies, what I call phase 1 or 1B studies, really just looking at safety and feasibility. Can we do this? And so Jacob Laubach from Dana-Farber presented data at this year's, last year's American Society of Clinical Oncology meeting of a trial looking at VRD plus Elotuzumab, which is one of those new antibodies. Newly diagnosed patients, they got 4 cycles of the 4-drug combo. If they were a transplant candidate, they could go on to transplant. If they were not or chose not to do it, they got 4 more cycles of Elo-RVD. And this was a very small study, only 40 patients enrolled so far. And what you can see is the response rates were good, 82% overall. 40% VGPR, 15% CR, but not that much higher than what we have seen with some of these triplets historically. And it was much better in the group that went on to transplant versus those that didn't. And part of this, I think, was there was a lot more dexamethasone used in this trial. And a lot of these patients ended up with infections, pneumonias, even sepsis, that might have limited the efficacy. And so this trial is being rewritten with less steroid, and they're doing larger numbers of patients to see if this is going to have an impact. But I think so far, at least, this initial experience was a little bit disappointing. But it's still early. The other 4-drug combo that was presented at the same meeting last year was, again, a very small phase 1 study of Daratumumab with KRD, so really taking sort of our most potent antibody and perhaps more potent triplet. And this was given a little bit differently. The carfilzomib has been approved as a twice-a-week drug, but there's a way to give it at a higher dose just once a week. The Dara is given usually as a weekly infusion for 8 weeks and then goes to every 2 weeks and then monthly thereafter. And this was looking at just 22 patients, again, looking at could we do this safely. And the bottom line was there were no new toxicity signals that looked worse than the KRD alone. And they saw, after 4 cycles, 100% response rate in the 21 evaluable patients. After 8 cycles, now, again, getting up to close to 90% very good partial response or better. Still, though, not a huge increase in complete remission rates over what we might expect, but this was still relatively early. So the conclusion for this as well was, yes, we can do this. It looks like it's safe, but we're going to need to study it in larger numbers of patients. At least so far, to me, the responses are not overwhelmingly better than what we're seeing with the 3 drugs alone, but I think it's early on. And so this is really just the beginning, and this is sort of probably not even a complete list of what I was able to find of studies that are either open or in development, looking at new triplets and new quadruplets, 4-drug regimens for myeloma. And so we have these triplet-type regimens that are a little bit older, designed for non-transplant eligible patients, adding an antibody to Revlimid and Dex versus Rev alone, or using this new proteasome inhibitor called ixazomib, or Ninlaro, which is sort of an oral form of Velcade, if you will. So an all-oral triplet, very convenient regimen versus Rev Dex. We have the comparison of triplets head-to-head. I mentioned the ECOG trial, KRD versus VRD. There's an Italian study of KRD versus Kyprolis and Cytoxan and Dex. A British trial combining cyclophosphamide with KRD, and then a whole bunch of antibody trials adding the antibody to a standard triplet versus the triplet alone, both in the United States and Europe, particularly with Daratumumab, probably the more potent antibody. And it's going to be a little while till these trials read out, but I think this is likely to change the landscape of how we treat. If these trials are positive and show a significant benefit for adding the new drug without an improvement, a significant increase in toxicity, you're going to start to see these regimens being incorporated. But I still think, personally, this is not quite ready for prime time, and we need to wait for these data over the next year or two. Moving on, after initial therapy, for a long time, we've known that you can give a high dose of a drug called melphalan, and that could overcome initial resistance to chemotherapy. And these were initial trials done in the 80s and 90s where we didn't have a lot of these new drugs, and patients became resistant to the standard chemo drugs very quickly. And so there were 2 trials that showed a survival benefit of going to the high-dose treatment with transplant compared to just staying on the same chemotherapy, and that's ushered in the era of autologous transplant for myeloma. And the question that's been asked, as we have all of these new drugs like lenalidomide and Bortezomib, is do we still need to be doing transplant? Is there still a benefit now that we have better induction regimens than our old-fashioned chemo? And so this has been actually studied in several trials now that have read out. And the answer so far appears to be yes, there is still a benefit of doing the transplant, even if you get an initial regimen. And so there were 2 Italian studies that were lenalidomide or Revlimid based. They used doublets initially and then randomized patients to either go on to transplant, Mel 200, that's the dose of melphalan, that represents the high dose Mel, either for a single transplant or a double transplant, or just stay on some low intensity therapy. This is a regimen that's all oral, melphalan, prednisone, and Revlimid. And this is another one with cyclophosphamide, Revlimid, and Dex. And in both cases, if you got the transplant, your progression-free survival was much better than if you just got the low-intensity treatment. And actually, the overall survival was better, too. Patients lived longer. This is a trial that used a Velcade-based induction, a Cy-Bor-D, Velcade Cytoxan, again, randomized transplant or no transplant. Again, the patient stayed in remission longer. Progression-free survival was better if you did the transplant rather than not. The overall survival data wasn't available. And I think the one that's most relevant to our practice in the US, the IFM 2009 trial, which used, again, a modern triplet VRD After 3 cycles, again, patients either got randomized to do a single transplant, 2 more cycles of VRD and go to maintenance, or they just stayed on VRD and did 8 cycles of VRD and went to maintenance. And again, even with VRD, one of our best triplets, if you add the transplant in, you have a better progression-free survival than if you don't. Interestingly, though, at least so far, with about a 3-year follow-up point, the overall survival was no different. And in this study, about 80% of patients who didn't get the transplant initially got their transplant later when their disease came back. And so the interpretation of this trial, I think, depends on your point of view about transplant. If you're a transplant enthusiast, you say, oh, transplant still has a role here. You can see the progression-free survival is better than if you don't. The median additional time was about an extra 18 months in remission if you do it. If you don't believe in transplant, you can say, well, look, there's no difference in survival if you do the transplant now or if you wait and do the transplant later. And this has led some to be a proponent of this collect and hold approach, where you collect stem cells early, but you don't go to the transplant right away. You save it for down the road. And I think really the longer follow-up is going to help determine this. If the overall survival really stays the same all the way through, you could argue maybe we can do the transplant later. As long as you do it at some point. If these curves start to separate and the survival is better for transplant, then maybe not so much. And the caveat I think I'll say with this is that in all the transplant trials, only about 65 to 80% of patients ever did the transplant later, even though they all thought they were going to. And that's because a lot of patients end up dropping out. They end up having another illness, or they get too sick, and they never get to the high-dose melphalan, and they don't get the benefit of the transplant. And so I fall into the transplant enthusiast camp, and we are a transplant center, and that's my disclosure, so we do this. But we still think there's additional benefit here, that you have these drugs that kill off a large amount of myeloma, but there's some that might be resistant. You come in with a different approach with high-dose melphalan, you kill off more, and you gradually chip away at the disease and give patients the best chance of an outcome. And there's a confirmatory trial going on in the United States called BMT-CTN 1304 with almost the exact same design in 1,000 patients, and we'll see if that actually confirms these data. One difference is in the French trial, they only gave maintenance for a year. In the US trial, we're giving maintenance indefinitely. So we'll also help to answer that question of how long do you need to stay on maintenance when we compare these 2 data sets. Another question that comes up is, should I do 1 transplant or 2? You saw in some of those trials there was a so-called tandem transplant strategy, where you do the first transplant, and then 3 to 4 months later you're recovering, and they hit you again, and you do another transplant. And so this trial was a large US study designed to ask, is there a benefit of doing that second transplant? And so patients all got 1 transplant, and then were randomized to go either right to maintenance, to get 4 cycles of VRD, so-called consolidation, and then maintenance, or to do another transplant and go to maintenance. And the bottom line for this trial was that there was no difference in the progression-free survival whether you did 1 or 2 or did the consolidation. And so this has been interpreted in the US as saying, for our patients, 1 transplant is still our standard of care. We always collect enough stem cells to be able to do extra ones down the road, but we tend to save them for later. Now, I will say there's a European study where they did a similar type of design, and they found completely opposite results. And so in that study, the second transplant seemed to have benefit. But there were a lot of differences in the patients that were enrolled and the treatments those patients got beforehand. And so most of us who use a VRD-based induction, it's closer to the US study, and that's how at least I'm interpreting this. And I'm curious to see in the discussion if that's different maybe down here at Levine. And then the final discussion is just about maintenance therapy, and we have a lot of trials now showing that maintenance with lenalidomide, just 1 Revlimid a day, usually at lower doses, can improve the progression-free survival, can keep the disease away longer. And what we didn't really know is, does that improve overall survival? Some studies had said yes, some studies had said no. And so this was an important study published last year by Phil McCarthy, looking at all of the trials of Revlimid maintenance and pooling all the data, more than 1,200 patients, and asking the question, what was the impact on survival? And in fact, patients not only had their disease stay away longer, but they actually had an improvement in overall survival, lived longer too. So we do think maintenance really does have a role, and it's something that we suggest to all of our patients if they're able to tolerate it. What is the risk or downside of maintenance? There's been a lot made of this potential risk of other cancers that develop while patients are on maintenance, and this emerged in some of the studies. And in this meta-analysis, when they combined the data, they did in fact see a slight increased risk of either another type of blood cancer or a solid tumor like breast or prostate cancer. The risks were 6% versus 3% or 7% versus 4% if you got the maintenance. However, when they analyzed actually what patients died from, there were really no significant difference in deaths from second malignancies, but there was a big difference in deaths from myeloma. So if you got the maintenance, fewer patients were dying of their myeloma. So I counsel patients about this. I say there is a risk here, but we think the benefit of the maintenance outweighs the risk of the second cancer, and we just have to screen you carefully. And patients get typical mammograms, pap smears, colonoscopy, whatever they would normally do. The last thing I'll mention about maintenance is most of the studies have been on Revlimid maintenance, but you can use Bortezomib or Velcade as well. Not as clean studies comparing Bortezomib versus placebo, but this one trial, patients got 1 or 2 transplants and got Velcade maintenance or thalidomide, an older IMiD drug, for 2 years. And the group that got the Velcade had better outcomes for progression-free and overall survival. And so there is a schedule of giving Velcade maintenance, just a shot every 2 weeks, which we do utilize in patients who either can't tolerate or don't want to be on lenalidomide, or there's some data that higher risk patients may do better with a proteasome inhibitor, and we use this program. And so maintenance is evolving as well. I think there are trials now looking at either Ixazomib, that oral proteasome inhibitor, a more convenient option, and there are trials of Daratumumab as well compared to observation. So we may have some other single agent options, and then of course a lot of doublets. So what can we add to lenalidomide and make it better? And there were randomized trials looking at all of these combinations of 2-drug maintenance versus just the lenalidomide or Revlimid alone. And it'll be another couple years till these read out, but we may have a better way to keep the disease away longer. And what I think is probably more interesting than just sort of adding new drugs is what Dr. Usmani alluded to, this whole concept of response or MRD-directed therapy. And we're finally getting some trials where we're actually treating patients for a set number of cycles and looking at their response and saying, okay, if you've achieved MRD negativity, can we de-escalate and drop maintenance? Can we continue? If you haven't, should we change therapies and add more drugs? We really don't know if a patient remains MRD positive, if we can change that natural history by adding a new drug or switching to something else. And we need these prospective trials, and they're finally underway. So we're going to have a lot more information. And so I think the take-home points for newly diagnosed myeloma: novel induction regimens can induce deep responses really in the majority of patients these days, and we're much more successful than we used to be. 3-drug regimens are preferred. I still think VRD is our standard for most patients, but think about KRD in high-risk patients, and antibody-based combos are emerging. I still think transplant has a role with a progression-free survival benefit. Still waiting on about overall survival with modern induction. Len maintenance is improving progression-free and overall survival. A lot of new maintenance drugs and combos, and I think response-adapted and risk-adapted strategies are going to be the way to go in the future, so that we'll be able to actually react to what we're seeing in front of us and have data to support making a change or not. And with that, I will stop and take questions. Thanks.